Conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Monday, March 2nd, 2026. I'm Len Sierra, and I'll be moderating today with a little help from my only other moderator today, since Rick is not here, and that would be Dr. John. And all of you are very well informed attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors, and they are Foundation Medicine, Novartis, Telix, Blue Earth Diagnostics. Okay, and we are off and running with our only new person. Okay. Oh, excuse me. The old notebook fell on the floor. All right, so we have Tony Giacona. Tony, I'm going to go through a series of questions, and please answer them as I raise them, and don't jump ahead. We just want to make sure you stay in chronologic order of your treatment. So,
Okay.
Tony, how old are you?
I'm 73.
73. And where do you live?
I live a little bit north of Syracuse, New York.
Okay. And let's see, how did you hear about AnCan?
A neighbor of mine who is she's a registered nurse who's kind of been advising me through since my diagnosis. She told me about it.
Oh, terrific. And did you sign up for our reminders?
I think I did, yes.
Okay, so we probably have your email address.
Yes, you do.
Okay, good. And so, Tony, what was your, well, let me start with, when were you diagnosed first?
Well, I first presented with a PSA of 9.7.
Okay.
During a normal checkup with my primary care doctor.
Right.
And so then I was referred to a urologist, which I didn't get a consult with the urologist for about 6 weeks. And then it took several weeks after that to get an MRI. And so the initial diagnosis for prostate cancer was in March of 25.
Okay, so just about 1 year.
Yeah.
And which hospital or institution did you go to?
I've been consulting with Associated Medical Professionals in Syracuse, New York.
Okay.
That's where I was referred to, and yeah, I you know, they that's where I first got the first consult. They scheduled my MRI and 2 biopsies, and consult with the radiation oncologist, and then subsequently the surgery.
Oh, so you had surgery.
I had surgery on October 30.
Okay. And let's see. On the biopsy, did they notice any unusual pathology, something like intraductal or cribriform pathology?
Well, I've got a post surgery pathology. Most recently, the first the original biopsies, along with a genome decipher from back in May, showed that I was high risk.
What was the decipher score, Tony?
The decipher score back then was 0.92.
Oh, yeah. Okay.
The post-surgery decipher score is 0.997.
Okay. And so what Gleason grade were you assigned?
So post-surgery, the Gleason grade is 9, 5.5 plus 4.
Okay. All right. So you had surgery in October, and what other treatments have you had?
No other treatments until just this week. I started Orgovix and took the 5th daily dose today.
Okay. Post-surgery, did you have any PSA testing done?
Yes.
And when and what was it?
So the first post-surgery PSA test was on December 18th, and it was 0.38.
Okay.
And
when
then
did they start the Orgovix?
Orgovix has started last Thursday.
Okay. Any reason why they waited a few months?
Yeah, because I was hesitant about taking it.
Oh, okay. Did they discuss possibility of salvage radiation therapy at any point?
Yes, that's what the current plan is. I've had 2 other PSA tests. January 15th was 0.59 and February 9th was 1.36. The plan is to, I started Orgovix, and the plan is to wait 6 months after the surgery in order to resolve urinary incontinence, and at 6 months after surgery to start radiation.
Okay. Did you have an enlarged prostate before the surgery?
I guess it was considered enlarged. The PSA was 9.7. That's why I was referred to urology. And then an MRI showed two spots. And
Where were the spots?
Pardon me?
Where were these spots?
I'm not sure where they were. The first, I actually had 2 transrectal biopsies. One was in March of 25 and one was in May of 25. The first one showed 1 malignant spot and 1 benign spot. The second biopsy showed 2 malignant spots and a benign spot.
Okay, but you don't know if they were confined to the prostate or if they were.
They were confined to the prostate. Yes. Yes.
Okay.
The both biopsies showed that the malignancies were confined to the prostate. Yes.
Okay. And so you said you started Orgovix just a week ago?
Yes.
Did they talk about doing a PSMA PET scan?
I've had 2 PSMA PET scans, one on September 2nd and one on December 31st after the surgery. Both were negative.
Okay. And just going back to the pathology report, do you recall if it said anything other than adenocarcinoma of the prostate?
Yes. I can read you the bullet points off the post-surgery pathology report. It says, so prostate and seminal vesicles, radical prostatectomy, adenocarcinoma of the prostate, grade group 5. Carcinoma involves approximately 6 to 10% of the prostate. Carcinoma spans an area of up to 18 millimeters. Apical, bladder neck, and perimeter margins are negative for malignancy. No evidence of extraprostatic extension. Right seminal vesicle is positive for carcinoma. Left seminal vesicle and vas deferentia are negative for malignancy. And then an additional comment, it says D2-40 stains confirm the presence of lymph vascular invasion.
So that sounds like it would be lymph node in the pelvic region. I don't know. What do you think, Dr. John, or anyone else?
Yeah, it was a little bit ambiguously stated there, but it sounds like the surgeon might have taken some lymph node samples, and the pathologist may have identified cancer in one of them.
Yeah, I don't think any lymph nodes were taken in the surgery. So just to go further down this report, it says extraprostatic extension, EPE. It says not identified. Urinary bladder neck invasion not identified. Seminal vesicle invasion present on the right. Lymphatic or vascular invasion present. Perineural invasion present. And then it says all margins negative for invasive carcinoma. And then it says regional lymph node status. It says not applicable, no regional lymph nodes submitted or found.
Okay, that's good news.
So lymphatic invasion is the word that they use. I don't actually really know what that means.
Yeah.
It's not as if a lymph node is lying right up against the prostate, or maybe it is. Maybe they're just some lymph vessels, lymph channels. They're a little like blood vessels, but filled with lymph. Maybe they run across the prostate and got invaded a little bit through the capsule, but I have never heard that phrase before.
Which phrase are you referring to?
Lymphatic invasion.
Yeah, lymphatic. Yes, this line item says lymphatic and / or vascular invasion present.
So we'd like you to ask your doctor exactly what that means, because it's a little confusing to us.
Yeah, I had that too. It means that the cancer has started to go up the lymph channel, not just in the node itself.
It's T3B. Does it show an N something?
It's it says okay, so it says PT category is PT3B, yes, and then it says PN category, PN not assigned, no nodes submitted or found.
Okay. All right. It's still a little bit unclear to us. So if you could ask them about what they mean by lymphatic invasion, and yet negative for lymph nodes, we'd like to know that. But okay, so you're on the Orgovyx. When's your next PSA planned?
Well, my next appointment, I have an appointment with my oncologist 2 weeks from today. and I'm assuming that he's going to ask for another PSA, which, yeah.
What is the name of your medical oncologist?
He's Dr. Stephen Duffy.
Okay, and do you happen to know if he specializes in prostate cancer?
I don't know that for sure.
Okay.
Yeah.
Maybe one of the guys can look that up. Stephen Duffy, and what's his, is he with the Syracuse Medical Associates?
No, actually,
Sure.
I changed providers.
Okay.
Cards on the table. And maybe people with more experience here could tell me if I'm off base, but I thought that, I first presented with elevated PSA in October of 24, and every step of the way took 6, 7, and 8 weeks. And I didn't end up in the operating room till a whole year and 2 days later. And in the very beginning, I was given assurance that I believed that they said, whatever, you're in here with 9.7 PSA, and there's guys that come in here with PSAs in the thousands, and whatever your problem is, we caught it on time, and you'll most likely, with a few outpatient radiation treatments, you'll be cured.
Well, you made the right choice, Tony. You made the right choice getting away from those people. So where are you now?
So Dr. Duffy is with Hematology and Oncology Associates. It's HOACNY. And I had my
general oncologist, Len.
General, okay. So
Yeah.
we're all going to be recommending, Tony, that you find yourself a medical oncologist who specializes in prostate cancer. We call it a GU, genitourinary medical oncologist.
Okay.
I'm not sure where you could find one. If Rick was here, he could probably tell us.
Well, I think it was Rick last week suggested that I look up Dr. Daniel Pratt at Case Western. He's 5 hours away from me over in Ohio. So I went online and I filled out an online request for an appointment with him. And I did that last Wednesday, which was a day after, the day after I signed on last week. The day after that suggestion was made to me, and I have not received any response on that yet.
Do you have a number you can call?
I'll go back to the website. There's a number I can call, but I thought filling out that request was specifically designed for requesting an appointment with Dr. Spratt, and apparently nobody's monitoring that. So,
Yeah,
Dr. Spratt looks like he's a radiation oncologist.
yes.
Okay. So that's all well and good, but you also need a medical oncologist.
Okay, a medical oncologist that specializes in prostate cancer.
Yes.
GU.
John, what's the name of that Buffalo University Cancer Center? Do remember? Anybody remember?
I'll have it for you soon.
Yeah.
So nobody at
Roswell Park Comprehensive Cancer Center.
Yeah, Roswell Park.
Oh, Roswell Park.
How far is that from you?
Well, it's It's probably 4 hours. It's closer than Case Western.
Yes, actually, yeah, Buffalo, if you're not too far out of Syracuse, Buffalo is probably under 3 hours.
Yeah, I don't know. I don't know if that's out of. Yeah, I think it's a little more than 3 hours, but yeah, order of magnitude. Yeah.
Okay.
Yeah. So you don't know of anybody at upstate? It's in Syracuse, huh?
No, anybody know of a GU medical oncologist in Syracuse area? Well,
Yeah.
we'll have to do a little research for you, Tony, but I guess we.
Okay, Roswell Park's been brought up to me before. Yeah.
Yeah. Okay. Or maybe because you're going to the Cleveland Clinic for radiation, you might want to consider someone there. I'm sure they have.
I got a guy in at Roswell, Dr. Chatta, Chatta, GU Medical Oncology.
CHATTA?
Yeah.
The Wilmot Cancer Institute in Rochester, New York. How far is Rochester for you? That's a that's a center of excellence.
Yeah, Rochester's close. Rochester is a little more than an hour, less than 2 hours.
Wilmot Cancer Center and Cancer Institute at the University of Rochester is a center of excellence, and they may be a place to check out.
What's the name of it? Wilmot.
Wilmot, WILMOT, Cancer Institute, and they're in part of the University of Rochester.
Okay.
Just wondering, is that a self-described center of excellence, or it's not NCCN?
The NCI says they're a center of excellence.
Okay. It's got street cred. Yeah, so send a bunch of feelers out, Tony. See who picks up, because you have a pretty aggressive cancer and you want it treated as soon as possible.
Yeah.
Are there any questions other than what we've already discussed that you want to ask us?
My original purpose last week I had not started the Orgovix, and it was originally presented to me last year after the first Decipher genome classifier came back, and I had in my mind that they had told me that I was favorable intermediate until that point. And so when that genome decipher came through after the second biopsy, and they said I had to do hormone therapy, I rejected that premise, and I was dead set against that, because I thought I was at higher than normal risk for a stroke, higher than normal risk because of family history of heart trouble, higher than normal risk because of my own hypertension and high cholesterol, family history of stroke and diabetes. So that's why my first question that I would have had last week was, what does anybody know about doing radiation without hormone therapy?
Well,
just everybody, you know, all the great minds so far, and you know, all the advice is that without the hormone therapy, other treatments will result in suboptimal results, right? So that's why just recently I capitulated and decided to start the hormone therapy.
yeah, I think you made the right choice there, Tony.
Yeah.
I think all GU medical oncologists would recommend hormone therapy along with radiation for someone with your stage of disease. And I'm going to ask Jim Marshall what he'd like to say.
Tony, are you a veteran?
I am not.
Okay, you are not. Okay, I wanted to ask that. Also, within the deal, anyway, I have heart issues, hypertension, high cholesterol, or I did, until I took all the pills. And I was on the hormone therapy for 5 years, although I did develop heart problems after that. And so at the time that I returned to ADT, what they are telling me is that I will be on essentially Orgovyx. Oh, do you right now have a history? Well, not a history. Do you have heart issues today?
I do not. Actually,
Okay.
I had a stress test. Well, one of the first things Dr. Duffy did on my first visit was run an EKG. And prior to surgery last October, I had a stress test. And they're telling me all that cardio stuff shows perfect operation, no problems.
Hey, fantastic.
Yeah.
Good show, guys. So, Orgovyx, I don't know if it would affect you that much. I would think not, but I am not a doctor. So,
yeah, the biggest reason for the concern there is my father had blockage. He had a multiple bypass when he was about my age. But that's him. That's not me.
Well, you're on the right hormonal drug for a person with heart disease. So Orgovyx, evidence shows it's you're better off on that drug than other options.
Yeah.
Yeah. Well, of course, the only other option, which let's see, Dr. Schellheimer's not here. There's some who might suggest estradiol as a replacement for any androgen deprivation drug. But that's not standard of care, and you might have difficulty finding a doctor who prescribed that for you.
Yeah.
Anybody want to address that issue here for Tony? Or?
Well, you can go to the AnCan.com org website and look up Wassersug or estrogen, and it will show you. You can have a 1-hour video by Richard Wassersug about using estradiol.
Okay. I was in attendance.
The meeting that we had.
Yeah, I was in attendance for that. Actually, okay. I mentioned it to my current provider, and have not. It wasn't to my doctor, but I mentioned that, and I was told that Dr. Duffy has never prescribed estradiol, and I've yet to talk to him about that. I was under the impression that estradiol is sometimes given in conjunction with Orgovyx.
Yeah, at a lower dose, it is.
At a lower dose.
That,
Yeah.
that helps reduce some of the side effects, but
Right.
you
Right.
can use enough of it to completely replace, and it's got many fewer side effects. Well,
You know
Yeah.
what you could do is if you're concerned about your heart, get a little more information about your cardiac risk. I mean, yes, you have hypertension and you have cholesterol. Maybe you're on a statin right now.
Yeah.
There are little questionnaires, very short, that you can fill out to estimate your cardiac risk of having a cardiac event in the next 5 or 10 years. You plug in your blood pressure and you plug in whether you're a smoker and you plug in your LDL cholesterol levels. It comes out with a risk. That would be one way to find out if you're actually a low risk. Another way is some people go out and they get a coronary artery calcium score to estimate their risk. But you could talk to your primary care doc. If you're at a high risk for cardiac events, then you might want to be careful about your cancer selections. But if you're at a very low risk, then you don't have to worry too much about it.
Right. Yeah. The other concern that I had was some years ago, well, for a number of years now, I've been getting occasional recurrent ocular migraines. In fact, I had one today. I just get the visual part. I don't get the headaches that go along with it. When one of those first showed up, I didn't know what it was. I went to an eye doctor, and he told me that people who experience these ocular migraines are at a higher risk for stroke. And I don't know. I don't know what the degree of that is, but that was, there's about a 3% risk of a stroke taking Orgovyx. And I don't know if that increases if somebody has a, pre-existing risk or not.
You could also get some genetic testing.
Yes, I was just about to say that, Dr. John. Have you had genetic testing, Tony?
Well, just these genome deciphers, these 2 genome deciphers. And recently, before I left the other urology practice, I agreed to be screened for the BRCA mutation, because they're conducting a clinical test for a medicine called Serrana. It starts with an S and ends with a B. But at that point, I hadn't decided that I was going to take Orgovyx or not, and that was a requirement. But they sent out. They did take a portion. They took a portion of my biopsy and sent it for the BRCA screening, and that it's been several weeks since they did that, and I have not received a response yet. But yeah, I had that's done and still don't have. And my understanding is there's only about a 3% chance that I have the BRCA mutation.
Tony, what's your family history of cancer?
My grandfather had prostate troubles, but in my recollection as a teenager, it was never characterized as cancer. My grandfather, the same grandfather, died of colon cancer at age 85. He was diagnosed in his early 80s. My paternal grandparents, I don't know about. There's I had a blood aunt that had lymphoma, There's no breast cancer that I know of. I had a blood nephew, a child that had neuroblastoma.
Okay.
Yeah.
Yeah. So seems unlikely that you have any germline BRCA2 mutation, but
Yeah.
Hopefully, when you say they sent out a tissue sample from your biopsy, they were doing more than just looking for a BRCA gene. You know, they usually do screenings of up to 300 genes, depending upon which company you send it to.
Yeah, I don't know that that's the case. Yeah.
Yeah, I would ask them if they've done it, and if not, have them do it, or you can wait until you find yourself a GU medical oncologist.
Yeah.
And then you know, work with that person. Did they talk to you about diet and exercise, Tony?
I was given the rundown, the Orgovix education thing. I don't recall that there was any special advice about diet, and you know, they said exercise was good. Do some weight exercises. I walk about 3 miles a day minimum, and you know, they didn't have any major advice in that respect. You know, they asked me what I did, and they thought it was okay.
Okay, well, you should do weight-bearing exercise as well, especially now that you're on hormonal therapy.
Okay.
Keep the bones and muscles strong, because the hormonal therapy will cause muscle atrophy.
Yeah.
And lose some bone density. So to make sure you do some resistance training, weight training.
Right.
It might also be good to get your bones scanned for density now as a baseline.
Yeah, good idea, John. Do you know if you've had that done, Tony?
I don't believe I've had a bone scan. No.
No, not a bone scan. It's called a DEXA scan. It's a bone mineral density a scan. They don't have to inject anything. It's an easy test to do, and it would give us a baseline so that we can compare 2 years from now to see if the Orgovix has thinned your bones at all.
Okay, bone mineral density scan. Okay.
DEXA, DEXA.
Me? You had spelled something?
DEXA.
DEXA?
Yes.
Yeah, DEXA scan.
Oh, DEXA, DEXA.
Yeah.
Okay. All right. Last week it was suggested that I look into getting an Acumen scan that might show stuff that the PSMA doesn't.
Yes, that's possible.
Okay, I've sent that. I put that out on my patient portal, and I got a response from an assistant that when the doctor comes back, he'll answer that. So, but I got an appointment in 2 weeks, so we'll discuss this stuff. Yeah.
Please try to switch to a GU medical oncologist as fast as you can.
Okay.
If you do that, you won't have to be getting too much advice from us. Hopefully they'll give you all the advice you need. But of course, we're always here for you.
And we're happy that you're on the Orgovix now. You've probably had this cancer for, who knows, 1.5 years now. It's good that you got taking something now that will slow it way down.
Right. Okay. So I'm told that that we're waiting 6 months after the surgery. I'm still dealing with some urinary incontinence, and that's the reason why we wait 6 months. Is that reasonable?
Oh, are you
Yeah.
doing the Kegel exercises?
Yes, and I'm going to a pelvic floor therapist as well
Oh, great.
for that. Yeah.
Yeah, because the common wisdom, I suppose you'd say, is that if you have urinary incontinence when you get salvage radiation therapy, you kind of lock it in, the
Oh.
incontinence. So you want to try and clear that up before you get the radiation. Anybody
Oh.
disagree with that? That's what I've heard.
Okay.
CRI, they did say that you should wait for up to 1 year before you think that you're not going to have an incontinence problem forever.
Okay. I've been dealing with it for 4 months now. It's been 4 months since surgery, and I think that's longer than normal.
How many pads a day are you using?
Oh, about 2 or 3. It's
There
a
is
lot
no
better.
normal. There is
Pardon
no
me?
normal. I had no incontinence at all. Some people have it permanently. Other people takes 6 months, 8 months, 10 months. Some people it's even shorter times. So it's all over the place.
Yeah. When the catheter came out, I was going through 10 diapers a day, and now I'm down to 2 or 3. But I can't imagine being confident enough to go without diapers at this point.
That's all right. You're moving in the right direction. You brought it down quite a lot.
Yeah.
Just keep doing the exercises. You said you're going to see a pelvic floor muscle specialist.
I have been seeing her for about 5 weeks now.
Okay. You might ask her what's her prognosis for your clearing up the incontinence in the next couple of months.
Yeah. Well, she's confident in the progress so far, and has told me that it's a slow process.
Hey, there is a solution if you cannot become continent permanently. You can get an AUS, an artificial urinary sphincter installed, which will give you the ability to be almost completely continent. A lot of people get them.
Oh, okay.
They work quite well, so it's not a forever problem.
Okay, good. Well, that's good to hear, I guess.
And we probably better move things along.
Yeah. All right, Tony, thanks for coming. I hope we've given you a few things to think about and act on, and hope you come back.
Yeah.
Certainly, within 2 weeks after you see your doctor, and let us know what's going on. Okay.
Okay. Thank you so much. You've given me a lot to think about. Thank you.
All right. Very good. Thank you.
Yeah.
So we will next go to Jim Stewart.
All right. Hi, everybody. I just have a quick update and looking for some input and comments. Just for background, I've got the BRCA2 genetic variant. I was first diagnosed with prostate cancer in 2023, had a prostatectomy in May of 2024. Things were going along just fine. Then my ultrasensitive PSA started rising. It doubled within a 9-month period, went from 0.04 to 0.1, which generated me to go see Dr. Munster. She agreed that was of concern, so we had a PSMA PET scan done this last January, and that showed 2 areas of uptake in two lymph nodes. So I went back to see Dr. Carroll, and I was referred to a GU oncologist and radiation therapist. And I'm going to start Relogolix here this week. And then from there, I think it's going to, right now they're saying in a 3 to 4 month course of that. And then after 30 days, I'm going to have some radiation therapy, and then we'll see where it goes. The interesting part to me is that there was kind of a dispute between Dr. Carroll and the radiation therapist. The radiation therapist wanted to radiate the lymph nodes and the prostate bed, and Dr. Carroll disagreed with that. He said, given my my grid score showing that the prostate cancer cells were not sensitive to radiation therapy, and that there was no disease anywhere other than the lymph nodes, he said, no, don't radiate the prostate bed. Just do the lymph nodes. You don't want to go through the side effects and everything of radiating the prostate bed. So that's kind of the plan as I stand now. Like I said, I'm still kind of in the learning phase of all this. I start the Relugolix this week and go from there. And if anyone has any comments or pointers or suggestions, I'd love to hear them.
I'd like to suggest that we all standardize on how to pronounce these drugs, because I spoke to the company salesperson years ago, and he said, accent on the go, Relugolix and Relugolix.
Okay.
Makes it easier to remember, I think.
Relugolix. I might even remember that.
Easy. I think it's easier to pronounce anyway, and Relugolix or whatever.
Did you say your doubling time went from 0.04 to 0.1? Is that
the 0.1? Yeah, in 9 months.
Well, we've spoken about that a lot in this group. When you're that low, 0.04, and you go to 0.1, it's not really any reason to be alarmed, because at those low levels, one doesn't really talk much about doubling time.
Well, that's where the BRCA comes in, because that set off the red flags, and actually, it's actually doubled again in the last 3 months. So clearly, there's some active disease going on.
I got it. The BRCA, I forgot about that.
Yeah.
Okay, Jeff Markey, go ahead. Jeff has BRCA2 germline.
Yes. Hi, Jeff.
Hello there. Yeah, I'm 16 years in. I started off with surgery. I didn't have any. Well, they didn't have PSMA PET scans back then. So, but I had just salvage radiation to the prostate bed, and it worked for 2.5 years. But yeah, what you're having done sounds really good. And it's, the thing is, Orgovyx, you call it Relugolix, but Orgovyx is the name, the generic, the name we usually call it. And it will work quite well to keep your PSA down. It worked. I was on ADT for 2.5 years, and it kept me undetectable. Once it failed, I became castrate resistant, though, and I just want to let you know that for example, when I became castrate resistant, I went on abiraterone, Zytiga, and you take 4 pills. I cut back to 3 pills, and in 19 days, my PSA went from 0.2 to 1 when I just cut back to 3 pills. That's BRCA for you.
Yeah.
So you really need to be careful about what you're taking and keep it up, because the BRCA just messes things up. And but I've been here 16 years, and I've been undetectable for 28 months on Nubequa. So there's a lot of hope in the future, and we're all waiting for didn't come at ASCO this time, but we're waiting for the thing that works after these drugs were taken stops working.
All right, thanks, Jeff.
By the way, Pluvicto works better for BRCA2 people than for people who don't have it. So you're not going to be getting that for a long time, hopefully, but just something to keep track of. That if you have to get Pluvicto, you're in better shape. Only 1/3 of people really do well on it, and BRCA2 people do.
Okay, good to know.
One of the things I wanted to share was there's a trial of something called I'm going to get it wrong. It's like 2001. It's See if I
Oh,
can
yeah.
find it.
PNT.
It's like, well, it's an NSD2 inhibitor. It's in a phase 1 trial for prostate cancer, but it's in phase 2 trials for some other cancers. But apparently it reverses the epigenetic change that they've now found out is the reason that prostate cancer becomes castrate resistant. So anyway, so it's a new drug. Potentially, if it pans out, it can restore hormone sensitivity. So that's the idea. Anyway, I'll put some links on that in the
Oh, great.
They've also found, though, that if you're on ADT, you should also be on an ARPI. Apalutamide is in a study right now, a long-term study, because they find that being on an ARPI delays the time to castrate resistance. And
Okay.
just being on ADT alone, there's something like a 2-year median. It took me 2.5 years, but it's if you can also be on an ARPI, it delays that.
Yeah, Dr. Carroll mentioned that, but hasn't gone any further than him just saying that might be something we'll look at. So,
and Nubequa, darolutamide, is really easy to take, has very few side effects. So as an ARPI, it's a really great choice. But there's a lot of people here on it. I mean, there's got to be a couple of dozen people on AnCan that are on it.
Oh, okay.
Okay. So, well, did you have a question for us, Jim?
No, it's
just an update. Okay.
I appreciate. Yeah, I just wanted to give everybody an update and like I said, kind of have everybody give me any suggestions or comments as I go through this.
You're already in the Braca Brothers group, aren't you, Jim?
Oh, yeah.
Okay.
I have a question for you, Jeff Markey. Are you metastatic?
Oh yeah, I had to have a metastasis zapped on my spine about 3 years ago. I had 3 SBRT sessions. It was wrapped around my L4.
Okay, so you qualify as MCRPC for a PARP inhibitor, but you've never been on one, have you?
Right, that's because the side effects. Stark has been really reticent about using the PARP inhibitor at all because, a lot of people on it become anemic, and the drugs I'm on have worked well. So the abiraterone is what caused me to get the metastasis because abiraterone I was only undetectable 1 month out of 2.5 years. The rest of the time my PSA was from 0.2 to 0.7. So that allowed the metastasis to build, but hopefully, well, the study that showed that even if you're undetectable, you could still get metastasis. So hopefully Nubequa was keeping me safe, but you never know.
Yeah. Okay. Thank you. Let's go to Ed Francois.
Yeah, just a quick update. I had an appointment with my oncologist at Smilo about adding another drug, and he said he'd be okay with doing that, but there was no data to back up if it would be a benefit for me. So from there, I went for a second opinion with Dr. Audio at MSK, and she agreed, and she said there is no data to back up the benefit of a second drug, just to say the course that I'm on, and which they extended the Firmagon out to June of 2027. So both doctors agreed, they both said the same thing. So that's the course I'm going to be sticking with.
Okay. And you don't have any side effects from the Firmagon shots?
Well, just the small hot flashes once in a while.
No, I mean, I'm talking about injection site reactions.
No.
Good for you.
The day of and a couple days after, I have a a little bump where the injection was and a little redness around the skin, but that goes away in a couple of days.
Very good. Okay.
And you're still non-detectable?
Yes.
Great.
Okay, thank you for the update, Ed. And Al Latimer, you have an update for us as well?
Yes, I do. We're talking about how long ADT worked for me. It worked for, my PSA was almost was undetectable for almost 20 years before it started to rise. And but since then it's been a battle. I've been through Pluvicto, I've been through various couple chemos. A year ago now, I was on Jeptana, and it was keeping the PSA in check. You guys are talking about 1 and 2. My PSA was in check at 200. But then I got a ureter blockage, ureter constriction, and the urine blacked up into my bladder, and I got a severe infection from it, and also developed AFib from it. So I was off all treatments for almost 4 months while they were working on cleaning all that up. And then during that period of time, this was well, from last April until last August, thereabouts, my PSA went from 200 to 800. I'm using round numbers. And at that point, I started Taxotere and carboplatin and Abby, 200 Abby together. And it dropped my PSA down to about 300 over the next few months. So that was working very well. And then now I've had another gap because of holidays, and in January I got pneumonia, and so I was on more antibiotics then, and I was so no chemo then, so my PSA went up to 400 or so, and that's about where it is now. In the meantime, I've had, I think, 10 rounds, 9 or 10 rounds of the trio of drugs, and I'm going to have to stop that before much longer because the side effects are going to, the fatigue is getting worse, the neuropathy in my feet is getting worse, and so I'm looking around for other things to do. Rick sent me a note that there is a new drug coming out, a new, no, I just lost the word. No, a new actinium trial coming out that may be of interest to me. There's a couple other new trials coming out that may be of interest, but that's kind of where I stand. I'm going to be doing probably one or two more chemos, but I'm going to have to stop that before much longer. Been in constant contact with Dr. Belusic about that. So anyway, that's kind of where I stand. And if anybody has any comments or questions, all ears.
So Al, did you say you had fatigue from being on Abby?
Well, it's a combination of the three drugs that are causing the fatigue.
The chemo?
Well, so it's Taxotere and carboplatin and the Abby together that I'm doing now.
Well, a number of guys have switched from Abby to Nubeqa or darolutamide and found some relief from the fatigue. But you're on chemo, which could be causing the fatigue even more than the Abby.
Well, I had fatigue with chemo without the Abby, so I don't think it's all that much worse. It's just kind of a cumulative thing, The more you have of it, the recovery time just seems to be getting, seems to be worse. I'm right a week out now from the treatment, and I'm doing better this week. But I have a couple. Well, I just, I take a nap and I'm okay. So, or I take 2 naps and I'm okay. And I try to exercise when I can, and just day by day.
Well, you're doing great.
Darolutamide intensifies the chemo triplet therapy, and that I've got a slide here about it, that it can intensify triplets. The darolutamide is supposed to be very beneficial for use with chemo because it can intensify it. So you might want to check with your doctor about that.
Okay.
This was from this slide is from clinicaloptions.com.
Is that something that's new? It's because I said, is that something that's just out now? There's some new study.
Well, it was approved at least a year ago, triple therapy with ADT, darolutamide, and chemotherapy, docetaxel, actually.
Okay. Well, I'm still on ADT too, so I'm past triple therapy.
Well, that's not actually, you're on triple therapy is chemo plus abiraterone plus ADT. That's triple. The carboplatin is just part of the chemo, and it's all done at the same time, right?
Well, no, it's a separate infusion.
But you separate time. The infusion?
Well, no, it's the same day, but it's one after the other. But it is a separate drug. It isn't part of the Taxotere.
Well, the darolutamide is supposed to intensify those drugs, so it's just you could ask about that.
That's something I'll bring up with Dr. Scholes too, because he didn't mention that either. He's the one that recommended I do the Abby in addition to the other two chemos.
The Abby's listed as intensifying it as well, but Darrow's a lot easier on your body.
I see.
Al, you are an ultra marathoner.
Ultra marathon.
Yeah.
Ironman.
Yes, yes, I keep up. I'm Timex. I just keep on ticking.
You do.
That's right. Keep it up, Al.
Okay, thank you.
All right, Frank.
Good luck to everybody. Yeah, hang in there.
You too, Al.
We're going to go to Frank Chambra. Go ahead, Frank.
So my update is I finished my Pluvicto after doing the first 6 rounds, and then I did an extra 3. So that was what's that? I did an extra 4 treatments, so that was a total of 10. We decided to stop the treatments, and my PSA has gone up to 4.99, and that's where it's at right now. So I'm waiting to get into clinical study. Would either be the xaluritamig, or I would get the chemo, which would be, what's the chemo? Cabazitaxel. So that's where I'm at right now.
Frank, you've already had docetaxel?
Yes.
Okay. And you never had cabazitaxel before?
No.
Okay. Okay, so I don't know. Al, go ahead. Al Latimer.
Hi, Frank. I've had 10 doses of Pluvicto also. Just out of curiosity, what was your PSA when you started it, and what was the low point?
It was 200 when I started, and the low point got to 0.89. And then now it started to rise. Then it started to rise, so I went back on it. And then it went down, but now it's starting to rise again.
Yeah, so I was basically in the same situation, although I started at about 70 and it went down to 1. But the month after, that was after 6 treatments. But the month after I stopped, it started creeping up again. And so same kind of situation that you're facing now. So I eventually did some chemo. Well, I hadn't done chemo before that, but I did some chemo, and then I did some more Pluvicto, and the Pluvicto helped, but the side effects were worse the second 4 treatments, and so I didn't do it past 4. So, well, and so what'd you say you were going to do now?
A clinical trial.
Okay, well,
Which one is that?
yeah, so I was kind of disappointed with the Pluvicto that I didn't get any holiday from it once I stopped it. It just, in your case, I mean, going from 200 to under 1, that's really remarkable.
Thank
So
you.
Frank, was that clinical trial, was that for that antigen STEAP 1, STEAP 1?
Yes.
Yes.
Okay. And did they tell you that you're eligible for the trial yet?
Yeah.
Yes, I am eligible for the trial.
Okay.
I have to wait till April 22nd before I can sign the paper. What?
Okay.
You have to wait 3 months washout from the Pluvicto.
I have to wait my 3 months washout from the Pluvicto before I can start in the clinical
Okay.
trial.
Well, I hope you get into that. It looks like a very promising drug.
Yes, it does.
Yeah, I'm hoping to.
All right. Any questions for Frank before we move on?
Frank, again, what drug are you trying to get in the trial for?
It's hard for me to pronounce. It's called xaluritamig.
Xaluritamig. We call it AMG509. It's easier to pronounce.
Yeah, AMG509.
Okay, all right, thank you.
Okay, thanks, Dr. John, for that. And Steve Schuler, you are up.
Yeah, so I had just a couple of comments about the estradiol topic from a couple of weeks ago. I was unable to attend. And for those who haven't heard me talk about it before, so I'm on the supplemental version of that. So I was on Lupron and abiraterone, and then I used that as a supplement, and I had really good luck with that. All the things that other people have said about it, you know, less fatigue, no hot flashes, sleep better. I got back in shape partly due to that, I think. It helped reverse my bone density loss. I went from osteoporosis to borderline osteoporosis and osteopenia. I haven't had the DEXA scan yet this year, but at any rate, so all good things to say about it. But what I wanted to add to what other people had said was 2 things, really. First off, if you go that route, your insurance may not cover much of it, but you're probably better off going with something like GoodRx, and you'll find it's cheaper than going through your insurance. At least that's the way it was for me. So with insurance, it was like $65 a pack, and with the GoodRx, it was $13 a pack. So if you're looking into that, that's something you should look at. The second thing I wanted to mention was there was questions about the blood levels of estradiol at which different effects occur, and I think on the chat a couple of weeks ago there wasn't any information about that, but there actually is some information out there, and I'll put a link. So some of the same people who had done the patch study had done some earlier studies on side effects of low estradiol and at what blood levels those side effects are reversed. And so I'll put the link to that. And
Thanks, Steve.
so I mean, I basically went off of symptoms. You know, I kind of adjusted my patch level based on symptoms, but I'm a kind of a quantitative sort of a guy, and I wanted some backup for how I felt. And so I actually went to LabCorp and got some, I got estradiol tests a couple times just to kind of fact check my feelings, I guess you'd call it. And it was based on the information on the link I'll put in. So that's all I had.
What
So
number did
very
you?
interesting, Steve. This is very interesting. What correlation did you find, if any, between how you felt and what your estradiol levels were?
Right. So the fatigue seemed to go away with even the lowest level patch, which was the 0.025 milligram or 25 microgram. The hot flashes really started going away with the 50 microgram, and then I actually ramped up to a 75 and 100, and then back down to a 50. So that was what I stayed on for the longest time, was the 0.05 milligram or 50 microgram.
Can you
That's
talk
so
blood
interesting.
levels, Steve? Can you talk blood levels and correlate that with the dosage?
Oh boy, I have those numbers in my LabCorp readings, and I could give you that, but I'll put the link to the that I had. So it's this paper. Let's see. There we go.
You don't
So
remember?
that's the paper I was using. There's some other ones, but that was the best one.
Don't remember what blood level you had to achieve in order to get rid of your hot flashes, what blood level you had to achieve to get rid of the other symptoms you were having. You were talking about that, but you didn't specify.
Yeah, so I have a spreadsheet where I recorded all kinds of stuff, and I have that, but I don't have it. I would have to pour through it because it's got a lot of other stuff in it, but I could give you that, but I don't have it real handy. After I go on mute here, I can see if I can find that.
Was it over 200?
You know, so there's p mole per milliliter, and then there's picogram per milliliter, and you sometimes get different readings in, and there's like a factor of 3.57 is what I remember to convert between the two. But anyway, so I can find that stuff for you, but I don't have it at the tip of my. I'd have to dig and I'd have to look in my computer to give that to you.
Picogram is what they show for my results, and for what a woman should be at, and all those. It's all in PGs. So I guess that's really the one to look at.
And Steve, when you were talking about side effects, were you talking about estradiol mitigating the side effects of?
Oh, yes. Yeah, I mean, I had all the side effects. I had fatigue. I had, I did have bone loss, probably still do. I had hot flashes. I had like about a dozen a day, sometimes more. Night sweats. Let's see, a little bit of dizziness. It actually, lack of estrogen affects your balance control. There are some articles about that as well. So yeah, so I had the gamut of side effects, and
Okay,
it
so
helped with all of them.
You weren't referring to any side effects that you thought might be due to taking the estradiol.
Oh, no, oh, actually, yeah. So I should mention that I did get gynecomastia to a small amount before I then was able to convince the insurance to pay for the radiation to stop it. So I mean, I don't know. Hope this doesn't gross anybody out. I got slight boobs. But not bad. And then I got the radiation to take care of that.
Good. Any questions for Steve?
A quick question, Steve. The gynecomastia, is that heralding in by nipple just your nipples become more prominent?
That's right. So I knew it was coming on because my nipples started getting sensitive, but I actually had a little bit of that just from the ADT also, but it got worse with the estradiol.
I'm talking about prominence rather than sensitivity. I'm just wondering myself because I'm on Clomid, which increases estrogen, and I've noticed that my nipples have become prominent and just like hard.
Yeah, I think a little bit of that too. But what I really noticed was kind of a bit of growth, an annular ring of growth that I would say is maybe about a 1.5 inch diameter, maybe a little bit more than that.
Okay.
Yeah. Gary, go ahead.
Steve, I'm looking at this paper that you put in the chart. And there's I'm looking at table 1 and trying to interpret table 1. So does this mean that in order for estradiol to help your bone density, your estradiol number must be at least 40?
Yeah, I think that's how I interpret it. Yep. And that's, so that table, right, that's in p-mole per liter versus most of the blood tests you're going to get are in picogram per milliliter. And so you need to figure out the conversion factor on that. And my memory was that it was like a 3.57 is what sticks in my mind, but I can't claim that for sure.
Because I'm just looking at some of these numbers and they're higher than what's considered normal for a man's estradiol.
So you be sure that, you might be looking at the numbers for picogram per milliliter, and that table is picomole per liter.
Okay. Yeah, I'll bet I am. Okay, thank you.
All right, Steve, thank you very much for sharing. Mark N., would you like to go next?
Yes, please. I'll try and summarize this. I'm right in the middle of radiation treatment. I'm also on Orgovix. I don't know how many details you have or you need. My question, I'm looking for some input and comments if anybody has any. My current cancer classification is unfavorable, intermediate risk, localized. I've read a couple articles in JAMA and Urology Times, and they both suggest that ADD duration for they're calling this high risk is 9 to 12 months. So that seems to be a little bit of a disconnect because right now I'm on a 4 to 6 month program with about 28 days of a fractional IMRT. I think I'm sitting in a gray zone. So I see Dr. Tran, my radiation oncologist, on Wednesday for my weekly visit. And I want to ask him about this gray zone I'm in. And are we being too conservative on treatment? Well, I don't know, I'm kind of putting him on the spot because I'm questioning his expertise here, but I've got to ask the question because right now I'm unfavorable intermediate risk or at the lower end of high risk. And this is just a difference of professional opinion, and I'm just looking for clarification on this from Dr. Tran. So I just wanted to throw this out to the group to get any input there.
So Mark, you have IDC-P, right?
That is correct.
Which I think is automatically considered high risk.
Yes, that's what I've been understand, except Dr. Tran doesn't, I don't know, I guess he is not seeing it that way. Or I don't know, maybe he is. That's why I'm on the Orgovix and the radiation combined.
And did you say you have 48 sessions of IMRT?
28.
Oh, 28, okay.
Yeah, I'm sorry. Yeah, 4 to 6 months. And he's talking about stopping the Orgovix at 4 months. And that's what got me doing my own research here. Because I want to, you know, I'd rather this not come back. I'd rather do everything I can now up front. I'm not sure if this is enough, or I don't know what his reasons are for treating it so, I'm not gonna say lightly, I guess conservatively.
You did get those slides read, didn't you, Mark?
Yes, I've had them reread. They've been read 3 times now.
Okay, so we're confident about the diagnosis now.
Yes.
So Rick is texting and saying the same thing I just said, that being that you have IDC-P, you're considered high risk, not intermediate.
Okay.
That's how he got in this group, I think.
Yes, exactly right. And which is why I reached out, because I said, well, I got graduated to this group when IDC became known, and but I'm being treated for more intermediate program. And this is Dr. Tran. He's an MD Anderson, so I'm not, don't want to insult his expertise, but at the same time, I've got to ask.
And we were speculating about a brachytherapy boost as well.
I don't know what that is.
It's adding
brachytherapy. Yeah, I'm sorry. Yeah.
Yeah, we're adding it to your RT, radiation therapy.
Dr. Tran at one point mentioned brachytherapy. He mentioned SBRT. I decided to go this route just for fewer side effects, and but hadn't heard anything else about the brachytherapy.
So I'm conveying Rick's thoughts again right now. He's saying Dr. Kishan would say 6 months radiation therapy per his recent meta study.
6 months radiation or ADT?
Oh, Rick, you want to clarify that? Rick just said 6 months. I don't know. Hormone therapy. Okay.
Okay, hormone therapy. That makes sense. Yeah, I was going to say, good. Okay.
Yeah, right. 6 months radiation.
All right. So 6 months hormone therapy versus the 4 months. Okay, that makes more sense to me. For high risk, though, everybody's saying for high risk, 9 to 12 months hormone therapy. That's what I'm reading, and on the JAMA article, however you say that, and the Urology Times also.
You had sent away some genetic testing, I think.
Correct.
You said it got approved, but hadn't been done yet. You get anything on that yet?
Oh yeah, that's been back a long time. Decipher came in high risk at a 0.74, I think. Artero came in low risk, and Promise test came in negative. But Decipher or Artero, neither one have been calibrated for IDC.
Right.
So
right.
they're not counting that.
So Rick is saying, show that paper by Tran to your doctor.
Okay. Or
Oh,
show,
I'm sorry, show Tran the Kishon paper.
is that the JAMA paper or the Urology Times? I've got them both pulled up. They're just, I've got so many screens up right now.
Well, is the Urology Time just as kind of a summary of the JAMA article?
Yeah, and let's see, I'm looking at the JAMA article is Nicholas Zaworski, yeah, Dr. Yulun's son, and I'm going to mispronounce this, Abdinor Naveed. But I think what it boils down to is how this has been characterized and classified, because their Dr. MD Anderson's calling it intermediate and unfavorable intermediate, and the other is the lower end of high risk. So right now I'm being treated for unfavorable intermediate.
So Rick says Spratt is the last author on the paper he's referring to.
Okay, Spratt, let me look at all here. Yeah, Spratt is correct. That's it. Yeah.
That's the one he wants you to show to your doctor.
Okay. All right, I will do that. And like I say, I have a meeting on Wednesday with him. So I'm just going to say it as diplomatic. We've got a good rapport. I'm just going to say it as diplomatically as possible. And I'm always asking questions. So I'm just going to say, hey, look, can I get some clarification on this? I've read this and it's a credible article. It's not Reddit. It's not YouTube. And you know, we're treating this way. I just want to make, just clarification here.
Yeah. I suppose you could simply tell him, I'm not comfortable with 6 months. I'm much more comfortable doing it for 12 months. And, I'm tolerating it well, which I assume you are. If you let him know that's what you'd like to do, I can't imagine he'd say, no, I'm not going to do it.
Okay. Yeah, I might want to do 9 months. I don't know about, I'll say 9 to 12 because that was the range.
Yeah.
And,
You can always bring it up again at the 6 month point if he balks now.
Right. Yeah. And we were going to cut it off. Well, we were going to have a conversation at 4 months and see how things are and then decide if we want to go to 6 months or not. But,
Yeah.
And I don't know if the radiation should be adjusted. Right now I'm on, 5.5 weeks to 28 fraction IMRT. I don't know if that would also get adjusted because of the risk profile. I have no idea.
Well, you can see in general the influence from AnCan is going to be toward a little bit more aggressive treatment.
Okay. All right. Well, I'll follow up and ask him. And I appreciate it. Thank you very much.
Okay, Mark, thank you. And next we have our final contestant, Jay Mills.
Yeah, I don't have anything new to bring up, but thank you.
Oh, okay.
I'm good.
Okay, we have plenty of time, Jay, if you're worried about a time issue.
No, I think I'm waiting to hear from Dr. Abel on that letter I sent, and that's really all where I am.
Right. Okay. Yeah. So Jay is trying to get into that trial with Madden and Abel. although I understand Madden is leaving the NCI, so he's addressing his request to Dr. Abel, Melissa Abel.
That's right.
Yeah.
Okay.
Okay, yeah, so keep us updated on that, Jay.
We will.
Thank you.
Okay.
Anyone else have anything at all? Otherwise, we can close out early tonight.
I might say something.
Sure, go ahead.
Hi, Len. I haven't been here. I've been here.
Yeah, Jimmy. Okay, hi, Jimmy.
Yeah, I haven't said anything for a long time. I'm not saying, I figured if I was here at the beginning and you said, do you have anything? You always say no. The last time I was going to say, well, I hope not. And now I'm sort of in that place still. What happened to me is, it's so insignificant, I don't want to bring it up, but since it is related to, my disease, I've been in a remission solid 5 years now, undetectable PSA after a whole lot of treatment. And my PSA has always been less than 0.04 on the assay. This last time, it went from less than 0.04 to simply 0.04. So naturally, I wanted to jump off a building. But the truth is, of course, that is a very, very low number and a very small amount of movement. So if I come here and talk about it, and I see Jeff Marchi laughing, I see anybody who wants to laugh at me, please do, because at this point, I can't consider it anything to think about. Plus, what's going to happen? I did do something really like dumb. I went in like 2 days later and got another test. Well, of course, it was the same. But since I'm every 3 months, I go in 3 months and you just look for the doubling time. I really like that video that we put out where the guy was talking about focusing on the doubling time way more than the number. That was a fascinating discussion. I guess everybody knows, or many of you know what I'm talking about, right?
Yeah.
That was really, that was something. I love the fact that it seems like the analogy that he made to, 3+3s getting overtreated and all those prostatectomies that didn't need to be done in the old days. And now it's like they're going after the idea of attacking recurrence at such a low number. And that a lot of times if the doubling time is slow, nothing has to be done for maybe quite a while. Well, I can only hope that's me. If I get my next test and it's significantly higher, well, I'll be back to talk about it, I guess.
Jimmy, how often do you get tested now?
Every 3 months.
Okay.
So who knows, I always like to come in and check in you guys and see how everybody's doing. But, after a while there, after so long of my remission, I felt like, I used to say I'm a man with no country, I didn't belong in low intermediate. I didn't belong in active surveillance, and I didn't belong here really. And I may belong here once more. Now, to be honest with you, I love you all very much. And I hope I'm never a full-fledged member again, but any of us would say that. But I certainly have got a lot out of this group, and I still do. So since there was nothing else to talk about tonight, really, I thought I'd just throw that little biscuit in there and back right off again.
Well, what did your doc say about the rise to 0.4?
0.04. Yeah. He said
0.04. She went from
I went from less than 0.04 to simply 0.04.
Oh.
I sure hope you make it until Thursday. I mean, you could get to men speaking freely if you're still.
I'm trying to hang on to Thursday. Yes, I try to make the goals. Set the bar low and see if I can clear it. Yeah, he said, sometimes it will stay there for a long while. Sometimes it'll bounce around. Sometimes it'll rise. You just don't know. So there was no reason to come and talk about it here, go to Dr. Gould or anything else. That's just the way it is. When it's that low and it starts looking like it's climbing from such a low number. That's why a lot of guys, including Rick and some doctors, guys have been on here say, I don't know why they test that low. Other guys say, oh, I want it to 3 or 4 decimal, 3 or 4 zeros so I can know what's going on. What's going on at 0.0003,
Yeah, that's crazy. I think almost all oncologists now consider they don't even think about doubling time until you're at least at 0.1.
Exactly.
Some will say even higher than that.
0.5.
You're a long way.
But when you've been spoiled like I am, that less than sign disappears. You just start freaking out, and then you get a hold of yourself and you remember how damn lucky you are and how it's really nothing to even think about. And I haven't since that very day.
Good.
That article about using focal therapy after initial radiation that Rick has in the newsletter, just fantastic information. Here the doctors are saying salvage surgery is not really possible, though there are doctors that do it, but focal therapy not only works, is just as effective, but it has lower side effects because there's a high incidence of incontinence and permanent ED after doing salvage surgery, whereas the salvage focal does not have those issues apparently. Did you read that whole thing Rick sent out? It was pretty incredible.
Yeah.
I'll go back and read that.
I posted it on Mayo and people really popped up and liked it because people have radiation as their initial treatment and they're told, all right, you're done. And the doctors tell them, well, yeah, there's salvage radiation, but there's focal therapy. Both HIFU and cryotherapy is just as successful as what that article says if you go read it. It's pretty incredible. But Clyde was next, so I interrupted.
I think that it's uncommon after radiation to have a recurrence in the prostate. The recurrences are usually in lymph nodes or bone, not so much in the prostate, which they hit pretty hard with radiation. But anyway, I'm sure it does happen. Clyde, go ahead.
All right, I agree with the last guy about the low numbers and getting worried when it just goes up a little bit, and I agree with him totally, and I think you guys are great. I've learned so much just in the few times that I've been on this thing, and I want to apologize because my Windstream email was crapping all night long, so I missed part of the first part, but I appreciate you guys.
Thank you, Clyde.
Have you been in Atlanta? Have you been in Florida all this time?
Yeah, I've been here since November.
And you know what kind of winters it's been up here.
Yeah, I'm very happy to be down here in Florida.
Oh, you got a good thing going this year.
Yeah, even though even Florida was cold for Florida.
Yeah, I know. You poor baby.
You guys.
I felt so bad for you when it went down to 51. I cried for you.
Well, you see, that's the same way we feel about your 0.04 PSA.
Perfect analogy. Perfect.
Hey, Jimmy, was that 0.04, less than 0.04, the minimum of the place that you were tested at?
It was the minimum, yeah.
Yeah, okay.
Yeah, that's it. I had so much treatment. Like I figured, I talk about bullets left in the gun. I mean, I had surgery. I had radiation. I had abiraterone. I had ADT. I have an artificial urinary sphincter. I have a bunch of infections. I had a lot of treatment. And if I have to treat, I have a permanent lymphedema in my groin. I'm a mess. But on the other hand, I have full testosterone. I feel great, and I'm doing well. But man, I paid for it. I didn't mind paying for it. I wouldn't trade it for anything. But someday it will be different. I may have been overtreated. I don't know. But it's all in the past.
I listened to a great talk on YouTube. It's called Feynman Physics. It's a whole series. And it's AI generated image of Richard Feynman, famous genius physicist. And he talks on different topics. Clearly, it's not really things that he ever said because they bring you, he died, I can't remember when he died, but it was at least 30 years ago. And, he's talking about topics that are in the news or in the scientific news recently. But the one I listened to today was why you lose energy as you age. And it was mostly focused on our mitochondria, which are the energy factories of the cells, and how they have their own set of genes. And because the genes are inside the factory where a lot of radicals, oxygen radicals, are generated, you know, those genes take a beating much more than the genes in the nucleus. And anyway, it's very interesting. If anybody wants to look that up, you'll understand why, as we get older, we lose energy. It's all due to our mitochondria.
You know how much I love to hear that, because it justifies the boring, unpleasant, but necessary work of all the cardiovascular exercise I do, which keeps the mitochondria moving and growing. And I'm a believer in that.
I'm sorry, Jimmy, I think I missed what you said about the mitochondria.
Mitochondria is very, it's keeping it moving and keeping it refreshing and at a decent rate is greatly enhanced by cardiovascular exercise.
Cardiovascular, okay, gotcha.
When you get older, yeah. And so without that, it just continues to, you know, you don't make more. It's like everything else, you know, it starts falling down and you wear out, and we're just slowing the decline. That's all we can do, right?
Yeah. Guys, it's open mic time for the next 6 minutes, or we can close out if nobody has anything they want to talk about. Well, sounds like a vote for closing out. Thank you all so much for coming and contributing, and we'll see you next Tuesday. Thank you.
Good night.
Good night.
Nice job, Len. Nice job.
Thank you. Thank you.
Great show.
Mr. Len, stop the recording. Oh, I don't think he did. I will.